Thank you very much. My topic is a little bit different from the whole symposium on late effects and survivors. Nevertheless, it's a very important topic for all of us. We all recognize that childhood cancer is curable, provided it is diagnosed early and treated adequately. Yet, every 3 minutes, a child with cancer dies somewhere in the world. And this graph, which all of us recognize as the survival gap between the high-income countries and the low-income countries, is still persisting in many areas of the world. So why do we have this survival gap? What are the causes for this survival gap? This seminal paper in Lancet 2003 by Metzer from Philippines showed very clearly that abandonment and toxicity were the two main reasons for a lot of children having been lost to follow-up and lost to treatment. And they, when they supported with transportation, food, social worker, and also included family and community education to address this treatment abandon, and this resulted in a massive improvement in the outcome of children with acute lymphoblastic leukemia, as shown in this chart here. So this is from Recife, 1980s early, when the abandonment rate were more than 20% and dropped down to less than 2%, as good as any Western center in the late 1990s. So in the next few minutes, we'll try to understand what is treatment abandon first, and then see how we can address that. Some of the countries report treatment abandon rates of almost 60%, which becomes a major contributor to cancer survival in children. It is reported as defaulting, absconding, running away, dropping out, discharge against medical advice, HAMA, DAMA, etc. So now it's a critical call for social response to decrease this treatment abandon so that the cancer disparities in various countries can be reduced and the survival gap can be covered. What is basically treatment abandon? It's a failure to start or complete curative treatment. My talk will focus more on the resource-limited countries, but it does happen also rarely with resource-rich countries. We look at why does it occur, why does it matter, and what can be done about it. This very nicely shows the dimensions of healthcare access. The 4 dimensions are the physical accessibility and location of the service. The availability and capacity is the second component. And then the quality and functionality is the third component. And finally, the fourth component is affordability. So if all these components are well in place, then the healthcare access becomes easy for the patient and the family. And if something is missing, then this definitely leads to problems in healthcare access and also leads to treatment abandon. Till 2011, we did not have a proper definition or uniformity about diagnosing or labeling treatment abandon. So in 2011, Mostert, on behalf of the SIOP PODC committee and the Abandonment Treatment Working Group, made this definition for treatment abandon, which is about 4-week time interval in which the patient fails to follow up. So that's a standard practice now that all of us refer to as when we talk about treatment abandon. And mind you, it's not only a sign of family failure alone. It's not the family that needs to be blamed for treatment abandon. It's rather complex, diverse, deep-rooted social factors, which we'll see in a minute. And complementary and alternative medicines, we recognize are valuable supportive therapy, but cannot obviously cure the child. So there are several social factors that lead to treatment abandon. Parental personal beliefs and coping mechanisms, which we just heard about. Inadequate finances is a major issue. Perceptions of disease incurability and treatment effectiveness. This is again a major problem in many situations. Sometimes we have very large familial household illiteracy and parental discord. So there is familial issues, socio-political instability and socio-cultural values may be a contributing factor. Again, negative experiences from the treatment, fear of chemotherapy, surgery, especially in cases where there is bone tumors. Then many families have a preference for CAM, complementary and alternative medicine. And there are several logistic issues concerning the hospitals, transport, food, etc. I'll just give one example here of this average daily wages in Indian rupees for male laborers in India. You see the maximum is 620 rupees, which is $10 per day. And the minimum is 160 rupees, which is about $2.50 a day. With this kind of earning or income for a manual laborer in India, it is very difficult to understand how he will cope with a major disease like childhood cancer, and especially with the other costs of treatment as indicated in this slide. The cost of therapy is not just the direct costs of investigations, treatment, blood products, antibiotics, but there are several indirect costs for food, lodging, transport, social costs, and obviously we don't tend to consider this loss of income and employment, which also contributes to all the cost of therapy that the family has to undertake. Then there are some, apart from the social factors, there are clinical factors. Gender is very important in some of the countries, especially in my country. Type of cancer, favorable versus unfavorable, duration of treatment. Most of the patients are noted to be abandoning treatment in the first few weeks of starting therapy. And then concomitant illnesses and especially malnutrition. Nutrition is one of the major reasons why families go away. This is a slide which I like to show always is about the life cycle of discrimination versus girls and women in India. At every stage they have to suffer from this discrimination, and which leads to a lot of discrepancy between how males versus females are managed in our country. Now, why does treatment abandon matter? For patients, it results in poor outcome. For families, there are social costs, there is reduction of morale. For providers, there is stress, burnout, lack of compassion, and fatigue also sets in. And entirely for the society, it affects the social perceptions about curability of childhood cancer. So abandonment is highly inefficient, costing time and resources, and therefore we have to see what we can do about it. Regarding strategies for addressing treatment abandon would be very highly context dependent on the country that are facing this issue. But major focus should be on finances. So we have to raise social capital, and I'll show you in a minute how we have managed to do that. Material resources, which includes a dedicated pediatric hematology oncology unit with adapted protocol-based treatment. This is again very important that reduced intensity treatment, which is adapted to the local situation, is used for this purpose. Patient education is another very important component. So health counseling of the patients, the community, regional and global partnerships can help in addressing all these situations. We have found that the employment of a social worker in the unit, and I'll show you that in a minute, is such an important step in making progress in reducing treatment abandon. Food, lodging, transportation, of course, needs to be taken care of for the families who are undergoing treatment. And with all these measures, Scott Howard in 2004 showed that treatment abandon in Recife, Brazil could be reduced from 16% to just 0.5%, which is the same as Germany. So this is what is possible with focused directed treatment. We have these, I've just listed some of the elements for success. This is similar to my previous slide. I'm not going to go through all, but these are the elements that can be utilized for reducing treatment abandon. Let us look at some of them. I refer to the most important parameter or most important approach would be what we call as the Therapeutic Alliance, alliance between the parents, the volunteers, and the society. So this alliance would help us to generate resources and which can be used by the system, health system, to have a favorable outcome in case of childhood cancer. So we work with charities. The most important charity that we work is with the association called Can Kids, and the founder of this is in the audience, Mrs. Poonam Baghai, and I'm very happy to share this with you that Can Kids has come into our lives since 2010 and has made a major difference in reducing treatment abandon for our families. The other organization is the Indian Cancer Society, which has a lot of activities, especially supporting our families with home care for the families that come from outside of Mumbai who are treated in our center. The other mention would be for Jeevdaya Foundation, which has a India Pediatric Oncology Initiative and has contributed tremendously to a lot of efforts in building capacity, especially for providing nursing manpower, social workers, nutrition management, data managers. Of course, data managers, one should not neglect. The contribution of data managers to track what is happening is equally important to realize where the fault lines are. And that becomes a very good feedback for us to take action. Teamwork. Teamwork is again very important to have good support with oncology nurses and social workers. This was one of our first social workers who joined under the collaboration with Can Kids. And within a very short period of time, a lot of difference was observed by them arranging a lot of events for the families, drawing, painting, birthday celebrations. You can see these pictures which demonstrate the enthusiasm of the children and how they are roped into various activities, including sports and many others. Stay, food, transport, and language. These are again very important to address. Most families have no place to stay in the metros, lack of good facilities for healthy, hygienic food. Many travel from distant villages regularly with no proper travel facilities. So all these things have to be addressed, and these are very minor issues, very difficult for doctors to focus upon, and therefore the collaboration with the support groups becomes very crucial. One last point that I want to make is about toxicity. We have crowded beds, cross-infections in many of the institutions that are treating children with cancer, and which leads to, again, mortality and treatment abandon. And for this, very important is to adapt the treatment protocol. We cannot use or transport the Western protocols to the Indian situation because it leads to a lot of toxicity and problems. So real-time protocol modifications would be necessary, and this has definitely reduced the amount of toxicity that we have seen in our children. The last point that I want to make is about networking. We have found that networking within the region, it's not about networking with countries abroad, but within the region becomes a very important way or mechanism for sharing care of these children and reducing treatment abandon. One example is the institutions in Hyderabad having collaborated with most of the districts, district hospitals in Andhra Pradesh, one of the big states of India, has resulted in a massive reduction in the treatment abandon in that area. The twinning between major countries, is also an important step which can help, but it's limited to 1 or 2 centers that can have this mechanism for twinning. So finally, I'm going to come to my conclusions that treatment abandon is a high burden in low-income countries. It's a reflection of collective societal values and priorities. Money is necessary, but alone is not sufficient. It's multifactorial in nature, and hence we require a multifactorial action. Collaborative team efforts are essential, and regional and global partnerships can improve the situation. Thank you.
Right. Thank you. Thank you, Bharat, for sharing the successful experience in India in reducing the abandonment.